Welcome and actually good morning on the Abstracts and Cases channel. Welcome to the Best Innovations session. My name is Andreas Baumbach from London, and I'm here with Salvatore Brugaletta moderating this session. Out of a large series of submissions, we have selected the three, which according to our scoring system came out top. Interestingly, in line with our three-valve theme for the course, we will be covering aortic, mitral, and the tricuspid valve. We have three fantastic talks, which we will go through and then discuss. Salvatore, I hand over to you to introduce the first speaker.
Thank you, Andreas. So I guess that we should start with the mitral, as you said. And the first talk also will be by Kari Kervinen from Finland.
Dr. Chairman, ladies and gentlemen, my topic is the treatment of mitral regurgitation, physiological annulus downsizing with an innovative helix ring. I shall show long-term results with a surgical model and mid-term results with a transcatheter model. There are unmet needs in mitral annuloplasty. There's a growing number of patients with heart failure and dilatation of mitral annulus. The dilated mitral annulus leads in mitral regurgitation. And in patients with heart failure, the surgical repair of mitral annulus possesses a high risk. Therefore, the available transcatheter meters for the reduction of mitral annulus are technically demanding and require highly specified teams. Therefore, a catheter-based procedure with a short procedural time and good long-time efficacy is urgently needed. This is the helix technology for transcatheter and surgical mitral repair. In the above pictures is shown the surgical helix ring. It's anatomically shaped, allowing the normal mitral valve function. It's clinically proven in the surgical setting. This is the catheter-based helix technology. It's based on the innovative ring concept. It mimics the surgical annulus downsizing and keeps the future treatment options open. This is the clinical human study with a surgical ring with 11 heart failure patients. The median age was 66 years, error score 2, 3.7. All 11 had severe mitral regurgitation. Concomitant operations were performed in 9 of these 11 patients. After 2 years post-implantation, the mitral regurgitation severity changed from severe to trivial or mild in all patients. All of the patients reached New York Heart Association Class 1 functional classification. No device-related adverse events were observed. This is the cath helix transcatheter implant for the mitral annulus. It's made from nitinol with full turns in the atrial and ventricular side of the mitral annulus. It attaches the annulus from opposed sides. It fixates through improgrammed compression and small barbs. It has good deliverability and steerability, low inflammation and thrombogenicity. It stiffens and gets to the desired shape in body temperature. Here's the catheter system, the delivery catheter with 3 steerable catheters achieving over 720 degrees turns in the mitral annular plane. This is the implantation procedure. First, there's the downsizing of mitral annulus with a balloon device in the coronary sinus. Then, through transseptal puncture, the steerable catheter is placed across the mitral annulus. The implant helix ring is pushed through the catheter. Then, the catheter, the red one, is withdrawn, and the cath helix automatically grips the mitral annulus through compression and anchoring barbs. No external fixation is needed. and then also the temporary downsizing balloon is pulled away from the coronary sinus. Here is an X-ray of the cath helix ring after fixation. The coronary sinus contractor ball is still in position. This is a 3D echo view from left atrium after cath helix implantation. Here is the mitral annulus and the annular groove, and the cath helix implant is there. And the enlarged anterior posterior diameter of the mitral annulus is successfully downsized with the ring. Here's a CT scan 29 days after cath helix implantation. The short axis view, LVOT, and the cath helix in the mitral annulus, 3D. And here's a long axis view, left ventricle, left atrium, and the cath helix in the annular plane, and the 3D. And let me summarize the preclinical data. Studies have been performed in sheep with heart failure and functional mitral regurgitation over 40 experiments. The steerable 3-catheter techniques work reliably. The procedure time varies from 45 minutes to 1 hour and 15 minutes. The animals are hemodynamically stable during the procedure. The dilatation of the annulus is reversed efficiently. The degree of mitral regurgitation is reduced after the implantation, and the endothelialization of the implant occurs rapidly. What are then the future studies with the helix technology? The safety and efficacy studies, GLP with diseased sheep, are planned to start in this or next year, and the pre-pivotal first-in-man study is planned to occur in 21 or 22. And the team of the Medtentia company is doing the development work, and the Medtentia company will do the future studies. And I want to thank the great Medtentia team for this. And thank you for your attention.
Brilliant. Thank you, Kari, for this presentation. I think this is intriguing technology. I must say I still have a question or two about the technique. So I put myself in the shoes of the operator, and I'm not quite clear how this catheter makes it round and round and round the mitral annulus, because I think that's what you're saying. The catheter has to go in first, and then the actual device is brought into the catheter when it's already got its shape, and then the catheter goes out. Is that right? I mean, maybe you can explain a little bit again how actually do you get the spiral around the mitral apparatus?
Yes, thank you. The steerable catheter, it has 3 parts. First, there is the thickest part, the catheter 1, that is driven to the atrial part of the mitral annulus, the anterior part. That bends maybe some 90 degrees. Then the second one, that is the most flexible or the most steerable catheter. It works just like EP catheters that are steerable. You turn the catheter and it then does the turn in the distal part. You turn the catheter and then advance it, and you do first 360 degrees curve, then you tilt it a bit or use the third catheter, and with that you then dive to the ventricular part of the mitral annulus, and then you also push and turn the second catheter. You can steer it, and then that does the 360 in the ventricular part of the mitral annulus. So that is pretty fluent procedure, but it is a high technology steerable catheter, I think.
Yeah, it appears so. And this is all transesophageal echocardiography guided or X-ray guided?
It is mostly echocardiography guided. So you have a 3D echo. You can see it from the atrial side or from the ventricular side, mostly from the atrial side, just as normally when you do, for instance, mitral clip. You look at it from the atrial side in the 3D echo.
All right.
Yes, thanks, Kari. So to me, this is a very interesting technology, and I agree with you when you say that this procedure can be simplified by using this technology, which is something, very difficult currently, because every hospital has a team dedicated to mitral intervention. I have two couple of questions. So one is for the procedure itself. I wonder if it is the same as for the mitral clip, that when you have to do the septal puncture, you have to do a septal puncture particularly high, for example, also for this catheter, it doesn't matter. And the other one, is about patient selection. Do you think, or do you have any data about the eligibility of patients to such procedure? Any kind of annulus can be reduced by using this technology, or there is a maximum size of the annulus which can be treated?
Yeah, thank you. The puncture in the sheep model, the puncture is done quite near the mitral annular plane. So about 1 or 1.5 centimeters from the mitral annular plane. So that is the best puncture site. Then the mitral or the patient selection, you can produce various sizes of those devices. So for instance, for the sheep, the sizes vary. The AP sizes, it varies from 30 to 50 millimeters. So you really can pretty easily produce different sizes. And then of course, I think that the major part of the patients will be heart failure patients with annular dilatation. And you also, after putting this kind of ring, you can then make, for instance, mitral clip if there's also some structural disturbances in the valve, or maybe in the future some valve in ring procedures using this ring, I think.
Yeah, it seems to leave a lot of opportunities. It might just be one part of our treatment armamentarium for the mitral. I've got one more question, and that is, you start the procedure by putting a temporary balloon in the coronary sinus and do a temporary sinus reduction.
Yes.
I.e. you pull on the thing, right?
Yeah.
Now we know from the devices that use that principle that it doesn't work in everybody, and it works to different extents. How important is it for the success of your procedure to get a sufficient pull and reduction of the annulus with this first maneuver?
I think that it is crucial for this procedure.
Crucial,
that you can,
yeah.
Yes. So it is.
Yes. So I think that's probably something that will also guide your selection process in the future, and it may work less in some patients where this crucial first step doesn't produce a sufficient result. We'll see. Well, in any case, a fantastic new technology, and I look forward to maybe seeing the first-in-man results at the future edition of London Valves. Thank you very much, Kari.
Thank you.
We move on. We move to the aortic valve now, and it's a pleasure to introduce Bart Meuris, who will talk about the first-in-man experience with a single-piece durable aortic valve therapy.
Hello, my name is Bart Meurs from the University Hospitals in Leuven, and I will talk to you about a first-in-human experience with a single-piece 3D shaped pericardial valve aiming for long durability. As you all know, there is a continuous search for more durable heart valves, and this is not only true within the surgical field of surgical prosthesis, but also in the TAVR devices. We are more and more aiming at younger and lower risk patients, so we need valves with a high durability and a low calcification. The innovation is largely driven by the industry, improving both tissue science and valve designs. But when you look at the currently available devices, both in surgery as in TAVR devices, there is still some room for improvement regarding the hemodynamics, the valve designs, and also regarding the biocompatibility and the anti-calcification properties of the tissues that we implant in these devices. I will talk to you about the latest innovation made by the company Anteris, formerly known as Admedus, and they have been developing the so-called DuraVar heart valve, which is a combination of two core technologies. On one hand, and I will illustrate that, you have the 3D shaping technology, which is quite unique. And on the other hand, we have the adapt tissue engineering anti-calcification process, which is well known in the meantime because it has been in clinical use for more than 10 years now. In this slide, there are the two core elements. On the left side, you see a short summary of the adapt anti-calcification process. Short, there is a very thorough and a very efficient decellularization process, and this makes this pericardial tissue quite unique in the whole field of pericardial tissues that are out there in commercial use. Next to this very thorough decellularization, there is of course a cross-linking with glutaraldehyde, followed by a decent and efficient detoxification process. This whole adapt process really delivers a tissue that is very resistant to calcification and degeneration, and this has been shown in many preclinical studies and also already in the clinical field. There are several publications regarding this process already available in the public domain. On the right side, you see the 3D tissue shaping technology, and I will come back to that because this technology is quite new and results in very high leaflet coaptation and a reduction of leaflet stress. I will illustrate this in the next slide. Here in this animation, in this short video, you see an illustration of how this 3D tissue shaping is taking place. And this is how the company can construct a single piece 3D shaped pericardial valve, resulting in a significant increase in leaflet coaptation area and a significant reduction in leaflet stress. What I will talk to you today about is about the surgical first-in-man implantation of this kind of device, but of course there is a large opportunity of implementing this technology into a TAVR device later on. What we did, together with the company, we designed a clinical first-in-man study to be able to implant this 3D shaped single piece pericardial valve into patients in aortic position and to see, to look at safety and efficacy and hemodynamic behavior at least at a 6-month time interval. Of course, this clinical study was only studied after the completion of successful preclinical work in juvenile sheep, and the results from this preclinical study is in the process of being published now. We were looking at regular candidates to receive a surgical tissue valve, and these people were asked to participate in this first-in-man implantation. On this slide, you see a very short video fragment which is showing the surgical end result of the implantation. I'm not going into the technical details of the implantation, but there is a continuous running suture at the level of the aortic annulus. And then there is a fixation of the commissures at 3 levels, just above the level of the native commissures, to fix this single piece pericardial valve into place. So a running suture at the base and 3 reinforced commissural fixation stitches. We were able, here in this video, you see 3 examples of how this valve behaves and how it looks like immediately after the surgery. You see 2 long axis views on the left-hand side and 1 short axis view on the right-hand side. You see that there is a very large coaptation area, a very nice opening and closing behavior of this valve. So the design of this valve is really aiming at reducing the leaflet stress and obtaining a high coaptation area. On the right side, on the short axis view, you can really see and evaluate a very large EOA that you can obtain with this kind of valve design. In this slide, we are summarizing the data from the first 5 successful implants. This is a pilot study aiming at 15 implants. In the meantime, we have been doing 6 successful implants, but I'm showing here the discharge data of the first 5 patients. You can really see the very low peak and mean gradients, very high AOA values here in this table. The second patient had slightly higher gradients, but this was a patient with a very narrow aortic annulus of only 18 to 19 millimeters, so it was to be expected that there were slightly higher gradients there. And here on the right side of the table, we summarized all the velocities measured at the LVOT and at the aortic valve, resulting in these DVIs, who are certainly at the very high end of the spectrum. Why is this study important? I think this is important because we are introducing the ADAPT treated pericardium, which is a treatment with exceptional anti-calcification properties and a complete desolarization. It is the first in human experience of this 3D single piece aortic valve design. And combining this anti-calcification properties with this new design, I think we are in the ability to restore normal pre-disease hemodynamics and potentially be a functional cure for aortic valve stenosis. In conclusion, I have shown you that there is still an issue with long-term durability and hemodynamics in the current devices that we are using now. We are in the process of doing this first-in-man pilot study, looking at early feasibility of this 3D single-piece pericardial valve with the ADAPT technology incorporated into it. The results show for the moment excellent hemodynamic behavior with very low gradients, high effective orifice values, and low velocities. And this technology is, of course, very well suited for later on development into a clinical used transcatheter device.
Fascinating. Salvatore, you want to?
Yes, this is, as you said, fascinating. So very interesting, presentation and technology. In particular, I like the 3D shaping, which to me, it could be a sort of customized medicine, in the sense that every kind of valve can be customized to a specific patient. I wonder, about the long-term advantage of such high coaptation and stress reduction, of course, so we don't have any data. But do you think, that this can have an effect on valve durability beyond 10 years, also on the valve resistance to sort of endocarditis?
Yeah. Good morning. Thank you for an excellent question. I think the large coaptation area can certainly help in enhancing the valve durability on the long run, because, I have been studying pericardial valves both in preclinical and clinical studies for all my life, and they fail mainly in the commissural parts where the stress is the highest. And by this large and high coaptation area and this specific 3D design, I think we certainly reduce a lot of that stress. Now, next to that, and I think equally important, and this is why I am involved in this technology, is the complete decellularization of this pericardial tissue, which I think tissue cellularity is still an important factor, an important element in potential valve calcification. So I think the combination of the efficient decellularization with this 3D design can really enhance valve durability in the long run. And this is what we are looking for the moment, because we are living in a tissue valve era where a lot of patients are asking for tissue valves also at younger ages.
This is, very interesting. And I wonder about also the fact, that every time that we implant a TAVI, so there is a question about TAVI durability, because there is this crimp process, which to many of us so can affect the durability of the TAVI valve when we do this crimp. So maybe, I don't know if you have any data about how this high coaptation stress reduction can maintain, the valve functionality after this crimp. So do you have any data about the crimping of this valve, if the function is still maintained or not?
Well, the company is now heavily working on their final TAVR device, and there are already preclinical studies going on in animals in a GLP lab facility. And I can tell you, I can't share the data immediately about crimping, but I can tell you that this technology also allows to go for a more thin pericardial leaflet. And I don't know by heart the amount of micrometers where they are at now, but it is certainly thinner than the pericardial tissue that we are using now. And this will certainly give possibilities towards catheter mounting and delivery later on.
So you're working on a catheter valve, but primarily it's developed for surgery, and I find it intriguing that this is a valve without a ring, right? It's sewn in as we've seen it. And I'm not a surgeon, but I wonder, does that require a specific skill set? Is it more difficult? I've seen implantations with a ring. You just go and sew in that ring. It's something you can easily put in. But isn't it more difficult to sew in a piece of tissue without something to fix it?
Yeah, very good question and very good point. There are two answers here. Certainly, it is slightly, we have experience with that because we have had other stentless commercially available valves as well, who had a pretty similar implantation technique. Now, I have to say, these kind of valves are not popular within the surgical field because, as you say correctly, they require more attention and it's slightly more demanding for the surgical implantation. And if you don't implant it correctly, there's a potential that it might fail or you have your aortic regurgitation. Now, I have always advised the company, and this is within their philosophy, that they are, for the moment, they are doing this first-in-man experience to look at safety and efficacy of the construct, but it is on the journey towards a TAVR device. There is also a potential field of evolution into a surgical stented frame, but this is more on plan B. We are looking at safety and efficacy now, which looks very good for the moment, and the plan is certainly to mount this 3D-shaped construct into a TAVR device, and this way giving the possibility to patients to receive a completely decellularized pericardial valve with this 3D design, with this high coaptation area. But your point is well taken. Within the surgical field, as the valve is now, I don't see this as a commercial success. This is an in-between step towards either TAVR or towards another surgical product.
One final question, if I may. I saw this echocardiogram. It's intriguing. One picture says more than 1,000 words. It just opens up completely, which is not what we normally see. So this might be particularly interesting for small annuli, where you want to have maximum hemodynamic effect. Are you aiming at that, or will this valve work across a large spectrum of sizes?
Oh, this pericardial sheath, I have them now available
ranging from size 21 to 27, but they can make any kind of size range available. And your comment is very correct. I mean, and this is also the reason why I'm still involved in this project. The EOAs of these patients in the postoperative phase are really large and are larger than what we used to see in some of the surgical, certainly the stented valves. And I think we can reproduce these kind of high EOA values and low gradients also in a catheter-mounted device. This is what we are aiming at for the moment.
Excellent. We're looking forward to seeing that in man. Great.
Thank you. Thank you.
Okay, so let's move now to the last presentation, which will be, so we will be moving on tricuspid valve. And our speaker is Stephen O'Connor from Ireland.
Hello, my name is Dr. Stephen O'Connor, Consultant Interventional Cardiologist at St. James's Hospital. And it's my pleasure to present our first in human experience of CreValve Duo, a novel percutaneous transcatheter tricuspid coaptation valve device for the treatment of severe tricuspid regurgitation. Tricuspid regurgitation, as we well know, is a highly prevalent condition with a significant burden on the health service. The incidence of the condition is approximately 550,000 in the EU and US alone on an annual basis. Most of these patients are treated medically, as we well know, with diuretic therapy, and most of them are unfit for surgical correction due to significant comorbidity associated with the condition. And so we've seen in recent times the development of transcatheter technologies to address this clinical unmet need. It's challenging as the tricuspid valve is a complex structure. In particular, in severe tricuspid regurgitation, there's huge variability in the anatomy. The annulus is often very stretched and dilated, and the annular tissue and the leaflets of the tricuspid valve is often very thinned out and friable. The valve itself is proximal to various critical structures such as the AV node, the right bundle His branch, and the right coronary artery. The CreValve Duo tricuspid coaptation valve system is a coaptation valve that's advanced through the right internal jugular vein through a delivery system and angled across the tricuspid valve, resulting in significant reduction in tricuspid regurgitation. We see here the temporary use and the permanent implant devices. The temporary use device on the left-hand side assesses the response, in particular of the right ventricle, to the significant reduction of tricuspid regurgitation seen. And the device is then retrieved. In the permanent implant device, a stent is used to fix the device in place. Once the stent is placed, the device is then adjustable, and once adequate adjustment is made with significant reduction in tricuspid regurgitation, then the device is disconnected from the delivery system. The coaptation valve is a nitinol frame with a soft porcine pericardium skirt. Here we see in the video below the native leaflets coapting against the cylindrical structure of the device in an atraumatic manner. There's a prosthetic valve within the cylindrical structure to support diastolic flow, and this thus reduces the risk of thrombosis. And here we see an animation of the implantation of the device with right internal jugular access under general anesthetic, TOE guidance, and intracardiac echo guidance. The device is placed in the right atrium, deployed, and angled across the tricuspid valve. Then, once the echo parameters are satisfactory, the nitinol or the self-expanding stent is deployed in the superior vena cava. The device is then adjustable after the deployment of the stent so that you get optimal reduction in tricuspid regurgitation. Once happy, then the device can be fixed and detached from the delivery system. As with any device, there's been rigorous preclinical validation performed with animal studies, durability studies demonstrating long-term device robustness, and various anatomical modeling has been performed using hugely variable CTs of patients with tricuspid regurgitation to assess how the device behaves in different anatomies, as this device is designed for a one-size-fits-all type placement. And it's my pleasure to present our early clinical experience of this device. These are the baseline characteristics of the first two patients with this device. This was performed on a compassionate use for patients with torrential or severe tricuspid regurgitation who were very symptomatic, with the view to then performing correction of the tricuspid regurgitation either through transcatheter or surgical correction. The annulae were very dilated in both patients. Both patients had at least moderate pulmonary hypertension, and there was an ICD lead plate present in one of the patients. And here we see the pre-screening echo and ECT for both of these patients. In patient 1 with torrential tricuspid regurgitation, and the CT modeling was used to plan the procedure from a point of view of advancement of the device. This was particularly important with the case here of the patient with severe tricuspid regurgitation, patient 2, with an ICD lead seen, and the modeling was used then to estimate whether the device would interact with it. And this is the second patient's implantation. You can see the placement of the sheath delivery system in the right atrium and deployment of the device in the right atrium with little interaction with the ICD lead. And then the device is angled across the tricuspid valve in the middle video here. And then at the end of the procedure, the device was retrieved. And this is the efficacy of the device seen in the first patient with massive tricuspid regurgitation, reduced down to 1+ with the device in place, with significant reduction in right atrial pressure and from 19 to 13. In the second patient that we just showed there, there's massive reduction in the tricuspid regurgitation associated with the ICD lead here, and right atrial pressure dropped from 27 to 14. Both patients had a uncomplicated post-procedure course. And so we describe the first in human experience of CreValve Duo, a tricuspid coaptation valve system. It's a novel approach to treat a complex undertreated condition. With these two cases, we've demonstrated safety and feasibility and ease of use and efficacy of the device. Further, 2 patients have been treated as part of an ongoing temporary implant first in human trial. The chronic device is undergoing preclinical testing and is for a first in human study in 2021. Thank you.
Thanks, Stephen. So this is another interesting technology that we have seen today. So my question, is about patient screening selection. No, you actually showed some interesting imaging about CT scan. I guess that CT should be done in any kind of patients. And I wonder, about the superior vena cava diameters. So is there, a maximum or minimum size for the implantation of this device?
Thank you for asking me to present, Salvatore, and it's a very good question. So from what I understand with the company's development for the permanent device, 3 sizes of nitinol self-expanding stents are going to be used for the permanent device. And this is deemed to cover the wide range of anatomies that we see with tricuspid regurgitation with regards to dilatation of the SVC. And so the idea of a self-expanding stent also with an oversize of approximately 20% it will likely cover most anatomies in this respect. Also, the nitinol stent is shaped in a conical manner to adapt to, as we know, the SVC is much wider at the entrance to the right atrium and then tapers down as we head northwards towards the head. And so the stent is shaped to accommodate this size.
Okay, thank you. And any additional advantage that you see as compared to other kind of device which are so far available in the market, like for example the tricuspid clip?
Yes, it's a very good question. I think we have tricuspid edge-to-edge repair, mitral annuloplasty rings, and tricuspid valve replacements. And all of those devices have their limitations when it comes to anatomy. For example, tricuspid valve repair, as we well know, is limited in very stretched annulae and failure of coaptation. And the design of this coaptation valve device is that it's a one-size-fits-all type valve for a condition that's very varied, that has very varied anatomy. And so that's the advantage of this. So from anything from relatively minor annular dilatation, organic tricuspid regurgitation, to functional, very stretched annuli with poorly coaptating valves. And so that's the advantage of this valve system, in my opinion.
Thanks, Stephen. I mean, if I may have a last question, which is just a yes or no. So I guess that oral anticoagulant will be forever in this kind of patients.
Yes, we're thinking yes is the answer to that question. I think the majority of these patients have atrial fibrillation, so they have another reason for as we know from many tricuspid studies, about 80% of those patients will be anticoagulated, and we see an indication for this. The design of the valve is nice, that it allows flow through the system. It has a valve within the cylindrical structure, and so allows for diastolic flow and thus reducing thrombotic risk. But however, it's still a foreign object across the tricuspid valve.
Stephen, this is yet another, brilliant idea and completely novel concept. I have a couple of questions. But first of all, just clarify for us or confirm, CRE valve. CRE is Irish for heart. Is that true?
Yes, it comes from the Irish or Gaelic or Gaelga. The Irish word for heart is CRE. So it's an entirely Irish company with the design from an Irish cardiologist. And so that's the design. That's the word I should say.
I have two questions at least. One is, you put a small valve in a big valve. Is there enough flow through this smaller orifice? I mean, the tricuspid is much bigger when it's open. Or am I not looking at this right?
Sure, that's absolutely a very valid point. And, the bench model testing does demonstrate good flow through the valve. And there has been estimates of also the gradient within the cylindrical structure not being excessive, indicating that there's adequate flow through this. And that's the whole idea, I suppose, of the design, is to result in diastolic flow through the valve.
The other question is, the valve is fine. The fixation is sort of a new concept. We've seen that with another tricuspid system with an anchor. But here you actually fix what looks like a little steel rod into a cava with a stent. The vena cava doesn't have calcium normally, or something to hold things in place. Are we not running the risk that this comes loose? How firm a grip can you achieve against the soft tissue of the vena cava superior?
Sure, absolutely. This is a consideration, and the only other data I suppose we have with SVC stenting is in patients with malignancies, where there's a compressibility of it. These are different patients, of course, and so in the animal model testing to date, it seems that an oversize of about 20% with a self-expanding stent seems to result in a very safe position. The valve itself endothelializes within 30 days as well, which will also help, I think, fixation in the longer run. And also the positioning of the valve is counteracted by the coaptation valve across the tricuspid, forming kind of an equipoise with regards to pressures. So we haven't seen any worrying signs, or the company hasn't seen any worrying signs in the animal model testing so far of the permanent device.
We'll have to see. One final question, yes, no, really. And once it's in, it's in. There is no way to remove it, right?
Yes, once it's in, it's in. There's no way to remove it.
Yeah, okay. Well, again, very, very fascinating technology, and we're going to look forward to see the results of the permanent implant study, maybe next year at PCR London Valves, I think, if the timeline is right and it all plays out. That brings us to the end of this session. We heard three, I still think, fascinating technology proposals in this innovation session on the aortic, on the mitral, and finally on the tricuspid valve. Innovation is really at the heart of PCR. Innovation is at the heart of what we're doing. Some of the things we see in innovation sessions, we will have in the cath lab in a year or 2 or 3. So it is always a glimpse in the future. I thoroughly enjoy these sessions and the great ideas that come along. And I continue to be fascinated about the future opportunities that we will have. With this, I just remind you there's other innovation talks available on this channel, together with abstracts and cases and some hotlines. And I thank our 3 speakers, and I thank my co-moderator, Salvatore Brugaletta from Barcelona, and I wish you all a good day.